Hello and welcome to this BMJ webinar. I'm Fiona Godlee, Editor-in-Chief of the BMJ, and our topic today is long COVID, otherwise known as post-acute, chronic or long-haul COVID. At the start of the pandemic, the focus was understandably on the acutely ill, saving lives of people admitted to hospital and minimising the risks to the elderly and vulnerable. Now a new and troubling phenomenon is coming to light. While most people recover quickly and completely from COVID-19, growing numbers are finding that they haven't simply snapped back into their pre-COVID lives. Instead, after what may have been only a mild initial illness, they are experiencing a range of troubling and sometimes disabling symptoms: breathlessness, cough, palpitations, exercise intolerance, mental and physical exhaustion, anxiety, depression, fatigue, inability to concentrate and brain fog are just some of the things being described. So what is long COVID? How common is it? Who gets it and why? What can those who have it do to speed up their recovery? And what can be done to support them? And what does this mean for healthcare, for public health, and for research? We have 6 experts with us to discuss this still poorly understood multi-system condition, including 2 clinical academics who are now themselves living with long COVID. We also welcome questions from you, the audience, which you can put through the Q&A function, and a selection of which we will put to the panel later on in the session. So please do send us your questions. Also, we welcome you tweeting about this on the hashtag BMJCovid. So I'm just going to go around to introduce the panel and to ask each of them to give their brief initial thoughts on long COVID. Let me start with you, Paul Garner, Professor at the Centre for Evidence Synthesis for Global Health at the Liverpool School of Tropical Medicine and Coordinating Editor of the Cochrane Infectious Disease Group. Paul, you wrote about your personal experience of what has turned out to be long COVID in the BMJ in May. I just wondered if you could tell us about what it was that made you realise that your symptoms were out of the ordinary, and what has been the response to what you wrote?
Well, the NHS website at the time said this illness would last about 2 weeks, and at 6 weeks I was still really unwell, and that's the reason I wrote it. It had a huge resonance among many people who were going through this madness at home. I didn't actually think at the time I would still be unwell and talking about this at 6 months.
Thank you very much indeed, Paul, and I'm very, very grateful to you for being with us. Moving on then to Nisreen Alwan, Associate Professor in Public Health at the University of Southampton and Honorary Consultant in Public Health at the University Hospital Southampton NHS Foundation Trust. Nisreen, you are also experiencing your own version of long COVID. What in your view, how in your view should we understand what long COVID is?
Well, thank you, Fee. But I did start my symptoms in March of COVID, and I was one of the people who read Paul's piece and was so happy and got validated really, and was sharing it with all friends, family, and close work colleagues. By the end of June, so more than 3 months into me not going back to my normal health, I was very frustrated by the fact that no one was counting us. I'm an epidemiologist, work in public health, and there was no quantification, no surveillance of people who have not recovered from COVID. And therefore the experiences of thousands and thousands of people were at large not validated and not believed. So then I started writing about how we can quantify and measure long COVID in the same way that we're doing with positive test results and deaths.
Thank you very much, Nisreen. Trisha Greenhalgh, over to you now. You're Professor of Primary Healthcare, Primary Health Sciences at the Nuffield Department of Primary Care in Oxford, and also a practicing GP. And Trish, you've just written with others an article in the BMJ about the management of post-acute COVID in primary care, which is being extremely widely read around the world. And in it, you make obviously a lot of very good points, but one I was struck with, which is that you say that it does not require a positive COVID test to be defined as having long COVID. And indeed, I gathered that neither Paul nor Nisreen have had positive or any COVID test. Tell us why that is important in the definition.
Well, I mean, first of all, when we wrote that article, we didn't presume to be the people with the authority to define what long COVID or post-acute COVID is. You know, we said for the purposes of this article, this is how we're going to define it. I think there will be other formal groups, for example, NICE, I guess, might want to sort of put a definition. But for now, since we needed a pragmatic definition for that article, what was evident to me as a GP researcher was that an awful lot of people who clearly had COVID-19 and who clearly weren't better had not had a positive test. And there's a number of reasons for that, but let's put those aside for later on in this webinar perhaps, and just say, you know, it is very, very obvious that some people, many people, perhaps even the majority, have not had a positive test, and let's not get into the argument that they can't possibly be defined as having long COVID unless they've had a positive test. So that's the marker we've put down, and nobody so far has disagreed with that. So let's see how we go.
Thanks very much, Trish. And as you say, that's something to discuss later on. Moving to Valentina Puntmann, Senior Clinical Investigator in Cardiovascular Imaging at the University Hospital Frankfurt. Valentina, you've been doing some very interesting work on myocarditis and MRIs of patients with a positive COVID test. Tell us about how that is helping you to characterize long COVID.
Thank you very much also for the opportunity to be part of this fantastic panel. So our experience with long COVID was really coincidental. So we have a long-standing research project in inflammatory cardiomyopathies, myocarditis being one of them. And we understood that the moment the autoimmunity word became linked to COVID, that we are looking here at something that we perhaps know a lot more, much better from other viral conditions. So we applied our tools that we luckily had in place, also in a sense that we could get to the diagnosis much faster, much sooner. Obviously, in Germany, where I'm based, the tests were available, so the COVID test, and we started our research by inviting patients that have had a positive COVID test, but not necessarily hospitalized, so anyone who would want to participate. And we were, to begin with, really shocked, because actually we thought we were doing a research with probably a very, very low yield, because we were a little bit later in the process of the COVID illness. We weren't able to bring people into the scanner while they were still recovering in a hospital, because simply they were out of bounds for us. So being a little bit later, we thought maybe we won't see much. And indeed, actually, the opposite was true. And I'm going to tell you all about it in a little while.
Thank you very much, Valentina. Look forward to that. Now, Nicholas Peters, you're Professor of Cardiology and Consultant Cardiologist at Imperial College London, so also in the cardiology sphere. And you've been telling us you have a cohort of patients who have been registered with the Hospital Trust for some reason, and that creates a very interesting database of people you've been asking about this. So what insights have you been able to reach about long COVID, Nick?
Yes, so first of all, delighted to be part of this and to share what we've learned. So yes, as a cardiac electrophysiologist, I have an interest in connected care broadly. So I used our patient portal, our personal health record at Imperial, to establish a questionnaire which we launched on the week of the 23rd of March. So from the first week of lockdown, and we've been running it every week since then, focused actually on physical, mental and social well-being in general, but we've adapted questions each week depending on what is current thinking and trying to predict future thinking. And as a consequence, we've got a very loyal band of around 10,000 regular respondents, but about 20,000 in total, some of whom have dipped in and out over what's now 21 weeks. And apropos of this discussion, over the last couple of weeks, we've been asking some specific questions focusing on longevity of the symptoms and recovery, which ultimately we will marry with the real-time weekly symptom reporting along the way. But A summary is that out of the 20,000 or so patients in total who have variously dipped in and out of the questionnaire, about 3,000 report thinking that they have had COVID-19 along the way, that they've had the infection. I should just point out, these are patients who by definition are registered as having had contact with my NHS trust. So some of them briefing outpatient encounters. The peak is in the 50s and 60s. It's a very representative distribution. And about 85% are Caucasian. So of the 3,000, we've had about half of those, 1,600 or so, who have given us information about the longevity of their symptoms. And out of those 1,600, about 300 report symptoms lasting longer than 2 months.
That's very interesting, Nick, and we'll come back to that later on. But thank you. That's a very important and helpful contribution. Although, of course, as we all know, we haven't yet got a decent denominator, a population denominator for any of this. So that's a problem. But thank you, Nick. So Tim, you've also made a pretty good attempt to get to the bottom of the frequency, if you like, as well as the kind of characteristics of long COVID. And just to introduce you properly, Tim, as Professor of Genetic Epidemiology at King's College London and leader of the COVID symptoms study. And the symptom app has helped to show that loss of sense of taste and smell was a real and indicative symptom of COVID, which hadn't been quite appreciated before. What are the data telling us about long COVID, Tim?
It was at least 10% of people who had COVID ended up having symptoms for over a month, and that number tailed off, but there's still, we think, about 60,000 people in the country with symptoms lasting over 3 months.
Thanks very much, Tim. And thank you all. Let me then turn back to Paul and Nisreen to hear more about your personal experience of this condition and what you feel that means more broadly. So Paul, would you like to just give us an account of what you've been experiencing, both in terms of your own experience, but also the response you've had more widely?
This is a very bizarre disease, and it affects you in waves. It's like being battered, and you are repeatedly battered over a period of time. And that was my first 2 months, and the subsequent 4 months really has been lesser episodes, but still very fatigued. I've sometimes been accused of misrepresenting long COVID as being only fatigue, but that is my experience, and it is clearly a wide spectrum of diseases or of conditions and complaints. Navigating help is really difficult. Partly you're muddled in your own head, you can't read things very well, there are multiple sources. The NHS is pretty appalling in its advice around managing fatigue. The best help I've got has been from the ME CSF literature on pacing, which tends to be underplayed in the NICE 2007 guidelines. So it's a difficult disease. I'd be interested in Nisreen's views here, but certainly dealing with it is a full-time job. And looking at the community of long haulers, there is a desperate need for good guidelines and advice. Trisha started this, but right now, we call for research, but we need people, specialists, working together in networks, getting good guidance out about how to investigate heart conditions and heart complaints. Who should be having echoes, for example? It's not entirely clear. It's a complete mess across the field. And you need coordination. And I would encourage people to look at the ICU NHS teleconference. I don't know whether you know this, but the intensive care people in the UK got the high volume centers together, 100 people on the call, 10 presentations. An email came out from Daniel Martin that shifted ITU care, certainly in all the hospitals that I've had contact with. And we need that kind of responsiveness. We haven't got time for papers, and in time it will be revised and improved, but that's a really immediate need. The only other two things I was going to say was the links to ME CSF for my condition are clear, and everybody sort of pussyfoots around this. Doctors don't want, I know a doctor who went back to work at 4 months before he should have done, simply to prove to himself he didn't have chronic fatigue. I mean, we are pussyfooting around this issue. And I also think we need to be realistic about the time needed for convalescence. If you've got someone who's 33, still in bed after 6 months with cardiac symptoms, they are not going to be back at work for at least 6 months. And I don't think people are thinking long-term enough about this time to convalescence. So, but thanks for letting me introduce this.
Well, thank you, Paul, and thank you very much for the pieces you've written, which I know have been incredibly influential in getting, you know, helping people to see that this is a real thing rather than something that is anecdotal. It moves us from anecdote to much more than that. Nisreen, tell us your thoughts on your own experience and what you feel needs to come.
So just before I share a bit more about my personal experience, I just want to kind of say, just for a minute, what is long COVID for those who have not experienced it? It's basically, my current definition, and hearing other people as well now, is basically not recovering several weeks or months following the start of the symptoms which were suggestive of COVID, whether you were tested or not. And most people, the profound fatigue is definitely a very common feature, but there's just this wide range of symptoms that people report in different combination, and they include the kind of the classical cough, breathlessness, muscle and body aches, but other things like there's this distinctive chest heaviness or pressure that people, including me, feel, which is quite concerning. And other things like skin rashes, palpitations, which I felt as well, you know, fever, headache, diarrhea, pins and needles, skin rash. A very, very common feature is the fluctuating or the relapsing, remitting feature of the illness. You feel you've recovered, and that's my personal experience as well. And so many times, that's it, you know, I made it, I've recovered, and then it hits you back, and it's kind of a constant cycle of disappointment. You know, not just to you, but to the people around you. You know, everybody's like really wanting you to recover, whether it's your family, you know, friends, and your people at work, because what's happening is you people are not going back to work, going back to work a bit, and then having to be off sick again, unable to do like their daily tasks and chores. I mean, for me, for months, I was struggling to open the freezer drawers and loading the dishwasher. And you feel like you've recovered and you start doing these things, and it starts all over again. So I think that expectation and the anxiety about, you know, about the recovery is a big feature. Have I recovered, you know, and have I made it? Naturally, I have, and some other have thought they've recovered, and it lasted for weeks at some point, and then it kind of the symptoms started again. My first symptoms start on the 20th of March, and it was just 3 days after my teenage son had a very short, brief symptoms of GI upset, and I started with that as well. But then I had the classical cough, fever, and again that concerning chest pressure and heaviness symptoms. And then the anxiety was what everybody, the initial anxiety was, am I gonna die? And you would go through those first 2 weeks thinking about that and focusing on your breathing and, you know, and your breathlessness. But then the anxiety that follows is like, why am I not getting better? You know, 2 weeks have passed. I'm still there. It's still coming, going. Some days are, you know, feels like I'm getting there, but some days I don't. And actually, what really helped me at that point was the informal social media account of other people basically saying, what is going on? We're not getting better. That was a great help to me. And then I actually, as I said, I felt better after several weeks, and I went full on back to work, worked really hard for a few weeks, and then crashed again, had to take time off work. So it's just, what happens is then you learn your patterns, and you learn what actually brings on this utter exhaustion, and you learn what brings on the other symptoms as well, and you try and avoid these things. And I think, to me, I feel generally better now, but I'm not sure whether I'm actually it's gone, or whether I'm just managing it better now.
Nisreen, thank you so much. That's such a very, very helpful description. And Paul, if I might come back to you, you've written about boom and bust and these false dawns, and how that adds to the anxiety and the difficulty, for example, employers and family members to actually maintain sympathy with you as you kind of dip in and out of feeling better and then relapsing again. Can you talk a bit more about that, and also how pacing is working for you?
Well, you look incredibly well. So, and I try and go out for walks, and people say, oh my goodness, you've got a nice tan. You look so well, as though I should be somehow flat on my back somewhere. And that in itself is quite strange. You say, well, no, actually, it's like this. And I'm fairly driven, and I thought that I could beat this virus. You see, I understood pacing, but I always took it to the absolute maximum. And it wasn't until a friend said to me, stop trying to dominate this virus, try and accommodate it. And actually, that's quite a good way of looking at it. You are not in control. The virus, or the response to the virus, is in charge. And once you start accepting that, then it becomes a little bit easier. But your baseline, you have to drop by 90% from what you were doing before. You are a different person, and you have to be very careful about overdoing it, because as soon as you overdo it, you throw yourself back into bed and unwell. And I have said that I feel privileged with my employer and my own situation. Poorer people that have to go back to work to put food on the table must be going through hell.
Thank you very much, Paul. I'm going to move now to Tim and Nick, both of whom have got some insights into frequency and, to some extent, the types of things that people are reporting. Tim, you've mentioned the 10% with still feeling unwell after a month, and this sort of extrapolation suggesting 60,000 people in the UK. Could you give us a sense then about the categories, if you like, of people with long COVID? I mean, we've heard about two slightly different versions of the illness from Paul and Nisreen, the kind of constellations or clusters of symptoms that people are reporting.
So there were these cluster of symptoms, and it seems to be that, but there's nothing specific that highlights there's only one thing that's going to tell you whether you get it long run. But we do know that if you've got persistent cough, hoarse voice, headache, diarrhea, skip meals, shortness of breath in the first week, you are 2 or 3 times more likely to get longer term symptoms. But we also, there's many ways of having long COVID. And so when we took our subsample that we knew have actually swab positive, so this is based on 3,000 people with positive swab tests, 98% of them had fatigue. Okay, so it is not just the odd wacky few, this is virtually everybody. 91% had headache, and then it drops down. They're the two ones, headache and fatigue, nearly everyone's got them. And then it was persistent cough, shortness of breath, and loss of smell. And they're the main ones. And then after that, there's a whole slew of others, and the combination of which seems to give you a slightly different risk of getting the disease or not. And our data suggested also that it was about twice as common in females as males. Although the Facebook entries have suggested this is sort of young females, we're not seeing that. It was actually it was slightly older when we compared it to people with what we call short COVID. This is people who've gone back to work at 10 days, the lucky ones. it was the age was it was about 4 years older. So actually, we got the full spread of age, and we seem to be getting different clusters at different ages. So it could be that there's a different type in younger people compared to, say, the over 65s, where some of these predictions break down. It's really quite interesting that as we get more data, we should be able to break it down into these groups and work out what's going on. So, there weren't, there was a slight increase in people who are overweight, but not dramatic. But we are now able in the first week to put the symptoms together and predict about 75% of accuracy of who's going to go on and get long COVID. So this could be very interesting in preventing future cases, by getting those early interventions going in those groups.
Tim, thank you very much indeed. Nick, obviously your database is a smaller database and people of a slightly different demographic, but tell us anything else or what you feel your data are adding to that picture.
Yes, well, just so everything conveniently breaks down into a kind of 80-20 split. So out of the full cohort, and I'll remind you, these are patients registered with my NHS Trust at any time in recent years, so not specifically to do with COVID. So they are a spread of patients with a spread of ages and demographics. About of those regular respondents to the questionnaire, about 20% reported having had COVID based on symptoms at some point. The vast majority of those were untested. About 80%, interestingly, predated lockdown and therefore predated the symptom, but predated the questionnaire, I should say, and reported this literally as soon as we started the questionnaire. So 20% have had it during the period of questionnaire, and I think that's quite interesting because the idea, and these people are, if we release the questionnaire late on a Friday rather than early on a Friday, I start to get emails saying, where's my questionnaire? It's really become part of their routine and they're very much a community. But just having the questionnaire doesn't seem to have surfaced a whole lot of reports of COVID, because as I say, most of them reported it, 80% reported it before we even started the questionnaire, before lockdown. 20% have reported symptoms extending beyond 2 months. And we haven't dug into the data enough to do any of the clustering, but for those who had symptoms that lasted at least 3 weeks, fatigue is by far and away top of the list, with again 80% reporting fatigue as being the principal symptom that extends beyond 3 weeks, with cough and shortness of breath coming closely behind. Interestingly, headache was present in only about 20%, and I mention that because it's a slight variance with what Tim said, but certainly fever is down on the list. So that's largely aligned with what Tim just told us. In terms of those that have had good days and bad days, I think is an interesting question, and speaks to the point that Paul made. Again, about 80% of those who've had symptoms that have lasted more than 3 weeks report having had clear good days and bad days. And 80% are now, after at least 3 weeks of symptoms, reporting either full recovery or minor symptoms only. So we're then left with 20% of those who had symptoms lasting 3 weeks or more, who now have major symptoms or the complete full house without any resolution of any of their symptoms. So that's a breakdown, largely 80-20 in respect of all those components.
All of that conversation leads me on to talk to Valentina Puntmann about the work that you've been doing, because underlying this conversation must be that question about what is going on, not only clinically, but pathophysiologically. And so perhaps you could talk us through what you've been doing, and we can then move on to discuss more broadly.
If I may, I would like to share some slides, and I'm going to try to bring out a little bit of what is the evidence so far and how do we understand the pathophysiology. And let me just be very, very honest. This is really tackling only the cardiac part. Where I really cannot speak for any other part of the body. So let me take you through this. So this has been the first, as in jotted down scheme of what we think the possible pathophysiological processes can be involved. It comes from the European Society of Cardiology, and even though it kind of has been validated through the experience, it's been a wide cast from the vascular, so basically coronary artery disease processes, till then coming also to the injury of the myocardium, so heart muscle itself, and complications related to this. But I'm going to try to bring these mechanisms a little bit more into perspective. When can we actually expect them to happen, so that we can also relate them to the patients themselves, as they put them alongside the symptoms as they present. Perhaps just important, why is heart involved? And this was a little bit not such a surprise, even though we were all focusing mainly on the lungs and respiratory symptoms to begin with, because the virus actually attacked the same receptor that is also abundantly expressed in the heart and not just the lungs. And this is also the entry point when it comes to the heart involvement. Now this comes from the Madrid group. So Madrid, sort of an observational summation of data. So patients that have been very unwell during the acute COVID illness and have also then sustained a heart failure. So really they have not done well in terms of the heart with the proper heart failure symptoms. And the important part that came out as an indication of which are the patients that are more prone to develop a heart failure during the acute COVID illness is that they have been on an oldish side, they have had heart failure in the past, and they have sustained atrial arrhythmias, meaning that their hearts were beating very fast during the COVID illness. So one other thing that came about as well is that those that have stopped taking ACE inhibitors, so patients with the previous heart failure that have been put on these medications and have stopped them, they did not do well. We can see here that those that had these medications withdrawn, unfortunately, did much worse than those that persisted with it. So this was one important message that we, as long as possible, need to keep up with these medications. So why are the ACE inhibitors important? So we know that if you have pre-existing cardiac condition, the cardiomyocytes, these are the cells of the cardiac muscle, express this receptor that COVID virus likes very, very much more. And this is bringing this predisposition to being more prone to be more unwell during the acute COVID illness if you obviously have a pre-existing cardiac condition. And also the reason that with ACE inhibitors, that ACE inhibitors help is that they normalize the expression of this receptor. So it is protective to stick to the ACE inhibitors during the acute illness. So I'm going to here sum up a little bit of a mechanism. So what actually happens during the acute illness? So obviously a huge stress on the heart, especially in the presence of pre-existing conditions. So hypoxia, because of the respiratory infection, the pneumonia, brings about ischemia of the heart. So heart is less well perfused, less well supplied with the oxygen, and this is definitely something that doesn't do well. So tachycardia, we have mentioned before, the atrial fibrillation, for instance, is something that makes the heart beat very fast, in addition to febrile illness itself. And in a combination with the pre-existing cardiovascular disease, this is what brings about what we also see later in the evidence troponin leaks, so leak of the or sign of the injury of the myocardial muscle. Now I'm going to show you a case from not our study cohort, but a case that fits this description. A patient that presented with previous conditions of hypertension. He was known to have atrial fibrillation, a mini stroke in the past, short of breath on exertion. This is how he presented. He had pneumonia to begin with due to COVID infection, and received CPAP, but also for pulmonary edema, not just pneumonia. His troponin was raised, but not critically raised. What was most striking is the BMP, so sign of active stretch of the cardiac muscle. And clearly ejection fraction, so pumping function, was reduced. We didn't find any scar. These are the scar imaging technique that we can do with cardiac MRI. So scar would be white, which we couldn't see, meaning there was no direct injury, no, so to speak, myocardial infarction that would cause such an impairment. Indeed, it was truly atrial fibrillation and tachycardia that has pushed him over the edge. So it was a very illustrative case in that sense. We measured the inflammation markers, which were also raised. So at the same time, so during the acute COVID illness, he also had inflammatory involvement of the myocardium itself. So with the T1 and T2 values, we can determine this. So this is what brings me to what we call chronic COVID illness. So this is the territory where we also did research. So these were our patients. So 71 days on average down the line. We've examined hundreds of patients that have been previously infected, relatively young, slightly older than the first study, 50-50 roughly when it comes to to gender. And what was interesting, 22 of them, so 22%, had some pre-existing condition when it comes to the cardiac conditions. 13 had a previously known coronary artery disease. None of them was known to have heart failure previously. So we found, in comparison to healthy and also risk factor match controls, that T1 and T2 values, so these are the values that speak for the inflammation within the heart muscle, were elevated. And that was quite a while down the line. And that was irrespective of whether they recovered at home or hospitalized. So both were up. Our troponin values in this group were also elevated, but there weren't that many that would sort of hit beyond the threshold of the myocardial infarction. So I do not think, this is perhaps very important to raise, that troponin cutoffs that we consider today as useful for understanding of cardiac injury are really well calibrated for COVID. And this is just a summary of these non-ischemic mechanisms, because it really relates to our discussion about symptoms. It's very different than how we understand usual cardiac symptoms. So we all think there must be chest pain, there must be short of breath. And that is actually not necessarily the case, because after this original injury, there is quite a significant time lag before the symptoms of what comes next. So symptomatic heart failure actually really take place. So with this, I'm going to finish, and I'm going to let other speakers take.
Thank you so much. Valentina, so as I understand it, really this was an unexpected finding of what sounds like quite high frequency of people with what might be considered a post-viral myocarditis or an inflammatory myocarditis of some sort. Is that, I mean, you've summarized that. I think the study in JAMA Cardiology found about 3/4 of people who had had a positive COVID test, unselected people, had evidence of myocarditis. Is that right?
That's correct. So 78% had something, of which 60% have active inflammation based on the cardiac MRI measures. And this was a huge surprise to us because we really thought we were completely too late to find anything. But then on the other hand, our experience with myocarditis is actually from the stage of heart failure. We have never done a systematic study after patients have had the flu to actually see what happens on the level of the heart. So maybe this isn't such a surprise after all. It is perhaps just an opportunity of how to get a better insight into this evolution of the disease that we haven't done so far.
Yes, thank you, Daphne. Nick, you want to say something?
Yeah, and I think that last point, Valentina, is important to make. I mean, it's long been recognized in the 150 years that the ECG, the humble ECG has been around, that ECG changes in the context of any viral illness are really quite common. And so your point about not knowing, not having done such detailed investigations in the context of any old viral illness means that I think we can't be very specific in respect of interpreting your findings.
Thank you very much, Nick. I'm about to go to Trish, but Paul, comment from you.
I think this is a really good illustration of why we need rapid interdisciplinary communication, because the screening for heart disease, we need guidelines for that. And, you know, certainly when I checked 10 days ago, the NHS rehabilitation website for COVID talked about getting on a bicycle as soon as you can and get exercising. So this sort of clash between what's coming out of the pathology and the recommendation, we need rehabilitation specialists to pull all these things together quickly, in my view.
That's very helpful. I'm going to move to Trish now because, as has been said, you and colleagues have written this piece about how long COVID should be managed in primary care. Trish, tell us really what your conclusions are.
Well, I guess it was an interesting article to write because, you know, we all know that there was nothing published on COVID, you know, 9 months ago. It was a completely new disease. And then we're talking about long COVID. Well, I can tell you there's almost zero in the literature actually about the long-term sequelae of COVID because it's a new disease. So we partly based the article on recovery from other illnesses, and that of course is problematic, but mainly, and this is important, we based it on Matthew Knight's, my co-author's experience of running a clinic for people who hadn't got better after acute COVID. So Matthew had followed 1,500 patients. He's a respiratory physician. And he said to me, do you want to write this article with me? Because we need to get the messages out to the GPs about, you know, what they need to do. And interestingly, I was just sort of trying to answer some of the questions in the chat, but there's one patient who said, one person who said, well, you know, I had COVID, was it 10 weeks ago? I've had 2 telephone calls with my GP and that was it. So I paid privately for more tests and I was found to have pericarditis, which kind of aligns with some of the things that Valentina's been talking about. You know, what we wanted to do was to emphasize Matthew's clinical experience that many, and in fact, probably most patients who are referred to a long COVID clinic are slowly getting better. That's the first thing to emphasize. Secondly, that some are not getting better and have serious things that need referring. And for the general practitioner and the burden of managing long COVID is going to fall primarily to the patient themselves, actually. I think that's what we're seeing, but also to primary care, where the patient is coming along to the GP saying, I'm still not better yet, can I have a certificate, you know, all that kind of thing. So one of the things we wrote the article for was to say to the GPs, look, you can actually manage most of these patients in general practice using the clinical skills that you already have. And those clinical skills are things like listening to the patient, documenting when the illness started, documenting what the symptoms are and how they've changed and how they fluctuate, as we've heard, being alert to symptoms that might suggest that the patient needs referring. Look, GPs know how to diagnose heart failure, or at least I hope they do. You know, they know how to suspect pulmonary embolus, those kind of things. So working through the checklists for, you know, serious cardiac, thromboembolic, respiratory, neurological conditions and referring appropriately, but also maintaining what we in general practice call relationship-based care, hearing the patient's story, honouring the story, as Rita Sharon would say, and following that story, because that story should be a story of gradual improvement. And if it's not, then maybe that's time to take stock and say, look, you know, I think it's about time we referred you to the respiratory clinic or the cardiac clinic or whatever. And so I think the sort of interface between the GP and these very specialist investigations and monitoring is something that we have to work on a bit. And the other thing to put a marker down for, now I've got the floor, is in the chat, there's a number of suggestions, and also on Twitter, from the occupational therapy community. And what the OTs are saying is, hang on a minute, we do rehab, we do monitoring people's progress, getting back to work, getting back to living the life they wanted to live. And I think that we should be in primary care, as well as in secondary care, working very closely with the people who really know about rehabilitation. So that's probably enough for me for now, is it?
Thank you very much indeed, Trish. I think it would be the chat has been very rich, and I think it'd be worth now turning to Nikki, who is our clinical scholar at the BMJ. Are you there, Nikki? Who's going to summarize, present us with some of the questions to the panel. Thanks, Nikki. Over to you.
Yeah, of course. So one question that we've had lots of questions about testing, and about why some of the tests come back normal, why you still have long haul effects around, you still have sort of long COVID while you're testing negative for COVID. And we've got loads of questions about subsequently whether people are being reinfected or whether it's the sort of rehab, relapse and remission that we were discussing earlier.
Lovely, thank you. Well, let's go to that testing one. We've already talked about the fact that having a positive PCR is not something that has to be part of the definition. But do you have any, Tim, you talked about this, about the number of people who have or haven't had a positive test and whether that makes a difference to the likelihood or the reporting of long COVID symptoms.
Yeah, no, we found similar data when we compared the positive test people to the people that we predicted positive based on our algorithms. So I don't think the test itself, and in the early days it was quite biased because only people going to hospitals or big medical staff were allowed a test. And in a way, that's why in our data, we excluded the first week of, so you couldn't get into our data unless it was incident data rather than you already had the problem when you arrived. So that cut out a fair bit of bias. So I don't think that's important. And I think, you know, initially, if you remember, we just had cough and fever as the only way you could be diagnosed and therefore get a test. And now we know it's very much more than that. And so I think the more interesting thing is there's some evidence, a little bit of evidence from our data, which we're just working on, that maybe your antibody response might be important in this. And there's some, it's not great data yet, but a suggestion that people with strong antibody responses do seem to have the longer term symptoms. And that might fit with this idea of the lack of fast clearing of the virus and therefore getting some immune reaction, whereas the people with maybe the faster T-cell response and the acute fever don't get the longer term symptoms. So I think increasingly, as we get more data, we should be able to get these clusters together to work out what's going on and predict, you know, get our predictions up from 70% maybe to 90%, and then really put these people into trials and get it sorted.
Thanks very much, Tim. Nisreen.
Yes, thank you. I'd just like to comment on testing. I think it might be useful to think about the long COVID people, long haulers, as maybe two cohorts. There's a first wave, There's a first cohort, people who were, remember, community testing stopped altogether in the UK on the 12th of March. There are thousand people who are suffering long COVID who, you know, didn't have that, you know, ability to get tested at all. So we can't just say that's, you know, that's fine, we'll ignore, you know, me, Paul, you know, all the others. We need to bring in the clinical definitions back again for them to have a solid diagnosis, because otherwise, you know, there's a lot of, you know, there is some sort of discrimination, as, you know, in terms of clinical care, really, in terms of who got tested, who didn't, that, and I think we need to
about whether you're then believed, if you like, to have long COVID, because it's purely reliant on your reporting symptoms and there's no objective test. Is that what you're saying? That
I think, as in many other clinical definitions, there are a lot of things are reliant on reporting of symptoms, and I think it's about having this big cohort of people, you know, like Tim's and Nick's, and actually having some sort of a coming together and having some sort of clinical definition. Say, actually, if you had all these combination of symptoms at that time, you at least have probable COVID, and then you move on. But then actually now what's happening is more and more people are getting tested. We're missing a huge opportunity because nobody's following on these test positive people. Nobody's asking them the question, are you better 4 weeks down the line, 6 weeks down the line? And that's a huge missed opportunity to quantify and measure, you know, long COVID, that really, not just as a research opportunity, but as a surveillance opportunity, as a you know, as we're doing with the test and trace, somebody needs to pick up the phone or text people who've tested positive and said, have you recovered? Are you back to your normal baseline health before the start of symptoms or before the test date?
Thank you. Paul.
So tests help rule in the disease, but they are unreliable in ruling it out. And the public think these tests are, well, they did think that they were wonderful, particularly the antibody tests, where we know that the government approved them on the back of 30 patients that the manufacturer provided data on, all of inpatients. So there was these tests were approved without any community people being part of it. And I think, so people go into an existential crisis when they have clearly had the disease and then they get a negative test. They go, oh my God, maybe I made it all up, or maybe I'm not immune and I'll get it again. And then the relapse comes and they think they've caught the disease again. So the public information about how these tests should be used is very important. And doctors themselves are muddled. So I've even had the experience myself. I'm antibody positive now, I'd like to let you know. You know, I was seen through an occupational health service, and there was a refusal about actually putting down that I had the disease because it was simply on symptoms. I'd had a severe illness, it was said. So I think it's extremely important we get this clinical definition and doctors signed up to this because of the long-term implications for employment and so forth.
And
Thank you very much. Yes, Nick. Oh, sorry, Tim first, then Nick.
Just a quick point. If anyone, you know, if anyone does have loss of smell or taste, that is the most sensitive and specific link to having a positive swab test and a positive antibody test. So, you know, really that should definitely be included, and people shouldn't, if they have that, really they don't need any other test. It's so specific.
Can I just quickly add to Tim's point? That's actually now just a standalone criteria in WHO probable case definition, just having that symptom.
Very good. Thank you, Nisreen. Nick.
Yeah, I mean, I think this discussion about test positive or negative is us coping with the public health policy that was adopted in this country. And some could say that this discussion is somewhat predictable down the line if anyone had given it some thought. It is a compromise, okay? We have a test in medicine. A patient presents with symptoms, they have signs, and you do a test to confirm or refute it. Arguing whether testing is a good thing is really to put the cart before the horse and trying to cope with where we are. But we are where we are, and I think we're doing a fairly good job. But it is a compromise, and I think we need to hold our hands up and say that it is a feature of public health policy, and other places where public health policy was different where there is testing available has to be less of a compromise. Okay, notwithstanding the good, bad, and the ugly when it comes to testing, okay, we are to some extent ugly because we don't have the testing. And just a question to Tim, can you just remind us in respect of your clustering, whether your cohort in terms of the long COVID signals you're getting were from patients who were inpatients and requiring respiratory support even, or are they the long burners, the long slow burners?
Virtually all of them were had not been admitted to hospital. So we're talking people who developed incident disease in the population that we just followed daily with the app. And so they're much more representative of the most people with long COVID in the population.
Yeah, and I think that distinction is important, and I think you're absolutely right in that respect. I think that is an important point of focus.
Thank you very much. Valentina, can I ask you to pick up the point that Nikki's raised from the Q&A group about whether we think this is persistent viremia, persistence of virus, or persistent inflammation post-viral clearance, if that makes sense. I think your data do give us an indication on that.
Super. Thank you very much for this question. So the early data from patients that have had biopsies in our group has consistently shown no viral presence. So we believe that this is autoimmune mechanism. There was another study from Berlin group from patients that have unfortunately died and then had autopsy of their hearts. And only in about 40%, there was still virus present. However, no active inflammation at the same time. So this virus and inflammation seem to happen separately. So viral infection, obviously in acute stage. However, this inflammatory response in the heart comes with a delay. And that's why we actually do think we, in the end, did the right thing of scanning patients later on, not to begin with, because we've seen much more.
Thank you very much. Nikki, other questions from the...
Yeah, another one that's quite popular is questions about how long these patients would be infectious for, because the current UK advice to quarantine until you're asymptomatic, sort of how does that apply to these prolonged symptoms or multiple relapses, and when are people safe to return to work?
Very good. Who would like to address that? Tim?
We actually resampled people who had had symptoms for over 6 weeks and sent them a Stan Department of Health test, and we found that initially 9% of them were still shedding virus. But when we repeated those tests a month later, only about 5% of that lot. So most of them turned out not to be real. We asked the virologists and they said it's likely to be very low levels of virus, very unlikely to be viable. And they said it's highly unlikely any of these people will be infectious, but they are quite likely to produce false positive tests if there's repeated screening. So it was an interesting lesson because, and also it might depend on the sensitivity of the test, picking up some of these very low levels of virus. But in general, when we asked about these results, we were very worried about them. The virologists were really quite relaxed and said they're very unlikely to be infectious or to, you know, or to be able to culture them.
Nikki, any more questions you'd like to?
Yeah, another one that is quite interesting actually is the identification of predictive factors, and what do we know about that so far, and has the analysis of the long COVID data helped us identify any?
The predictive factors for long COVID. Well, Tim, you've talked a bit about this and in terms of the initial symptoms, and then you've raised this fascinating point about whether a high antibody response is also in some way indicative, or whether that's predictive. Does anyone want to raise to Trish?
Yeah, I thought I'd get into an argument here. If you are a GP and a patient comes to you, let's say at week 4 or week 5, in a way, it doesn't really matter what happens to 1,000 patients, because the patient in front of you may or may not be heading for chronic COVID, if you like. And so whilst I think Tim's work is fantastic, Nick's work, you know, and people are putting out on Twitter saying these guys are doing just great stuff, documenting what the symptom clusters are. For the frontline clinician, the patient might have just about any symptom cluster, and that person might still go on to have chronic COVID, although it would be more likely if they had the hoarse voice or whatever the, you know, the specific things are. The point about it is that these symptoms are, you know, they're not 100% sensitive or specific for predicting what you're going to get. So in the end, what we've got here, and I think it's really important that we get our heads around this, we have a high degree of uncertainty around the future. And clinicians don't really like that. They like to send you for a blood test or an X-ray to say, yep, you've got that or you haven't got it. But that's not what we've got here. What we've got is a very, very uncertain, highly variable clinical picture. When I was at medical school, they used to say there were 3 things that can cause just about any symptom cluster: TB, sarcoid, and syphilis. And then just as I left medical school, we got HIV. Well, we've got another one now, which is long COVID. It can present in multiple different ways and affect people in very varied ways. And I think we need to be able to handle that uncertainty. And the way we handle the uncertainty, first and foremost, is by sharing honestly with the patient. We actually don't know how long this is going to last. We know that most people with what you've got are going to get better gradually, but we also know that some people with what you've got are going to have a much more drawn out illness, and some of those are going to have something that's really quite serious. So I think that honesty with the patient is really, really important. And also just believing the patient and saying, look, you know, you've got something unusual, but it's not unheard of. And we need to now go into a journey, however long it's going to last. I, your GP, am with you on this journey, and let's just keep tabs on you, and you know, those kind of things. So it's partly about the clever immunology, it's partly about the sophisticated tests, but it's also about handling clinical uncertainty.
And therefore, as you've said in the piece in the BMJ with your colleagues, not over-investigating if you can possibly help it.
Well, yes, but not under-investigating either. And some of the people in with the chat questions, and I bet their GPs are saying, well, come on then, who should I investigate? How aggressively should I investigate? And I would say, look, we don't know that, but if you are a GP with 10, 20 years experience, your own clinical instincts are probably not a million miles off where they should be. If you think, gosh, I really think this patient might need a troponin test, or I really think it would be a good idea to x-ray this patient, that may not be so far off. But I think to follow the story, to see whether the patient is improving, and to listen very carefully to them if they're telling you that they are getting worse. Particularly if they're getting rapidly worse. So they've gone along till week 7 and then suddenly they're more breathless. That doesn't sound right, does it? So let's get that patient seen promptly for the tests that they need. But if they are gradually getting better, then maybe you don't need to investigate them.
Thanks, Trish. Nisreen.
I just want to comment on the predictive question from a different angle, which is the prevention public health angle, because so in terms of characteristics of who's more at risk of death, we've heard a lot about that, and then we base public health, or public health policies been based on shielding or protecting the vulnerable and allowing a certain level of the infection to run in the community. Now with long COVID, we have no idea who's more likely to get long COVID, and as we just heard from everybody, there's so much uncertainty. Are these people going to get better? Are they going to, have long-term disability later in life? We don't know. So actually, this really shifts the public health narrative, because once long COVID is taken seriously, and we have no idea at the moment who's more likely to suffer from it, so we can't say these people have to shield or be protected. then that really is a massive shift in public health policy, in that we can't really accept levels of the infection to just run through the community, and we have to try and minimize that as much as possible until there's a accessible and effective vaccine.
Thank you for that, Nisreen. I just wanted some of the, Tim, do you want to come in there? Yeah.
Just to support Trisha and GPs, having a really tough job here with people that they're seeing at, 5 weeks or so. Our algorithms are not useful for clinical practice. They need computers and it's not that brilliant yet. But I think the important thing is to know, as we saw, 10% of people at 1 month, but only 2% at 3 months. So generally, between those period of time, GPs can reassure people that, 80% of people should be better by 3 months. It's unfair on the 3-month ones, but at least 80% of people, will be getting rid of most of their symptoms. And I think that's the other message, that it is decreasing, and although that tail's long, we shouldn't just give up at 1 month and say that's it.
Thank you. Paul?
I like Trisha's pragmatic approach. The only thing I would add is occupational therapists are incredibly valuable. They know how to manage fatigue a lot better than doctors. And the second thing is encouraging self-help and people to help themselves within communities. We've set up a small pacing group where we meet every week and talk about how we're getting on and swap stories. So encouraging people to work socially between themselves, because it is quite an isolating illness and it is a difficult illness to negotiate, and self-help groups that people can run themselves can be very helpful.
Trish?
Yeah, can I just put on my patient hat? A few years ago, I had breast cancer, and I can tell you where I learnt most from. It wasn't from my consultant, it wasn't even from the nurse. It was from fellow patients who said, this is what's going to happen, this is how you're going to feel about it, this is how to handle it. That was in a disease that was actually very well documented. And one of the things that I have found so impressive in my own research into long COVID is how peer support from patients, fellow patients, has actually reached the parts that the medical and clinical professions haven't reached. And I think we should, and actually I am doing a number of sort of focus groups and interviews with people with long COVID, including doctors, nurses, OTs, dietitians who've got long COVID. And I'm learning a huge amount from them. And they've learned lots from each other. So I think this is an illness where the research community, the clinical community, should be in partnership with the patients, because actually they're ahead of us in a lot of things. They're the ones that describe lung burn, brain fog. These are the things that are happening. We didn't have that in our lexicon. It was the patients that came up with it. So we need to make sure that we have a democratic partnership, both clinically and in terms of research.
I'm going to bring us to a close, if I may. Thank you very much to everyone, and thank you to the questions. And I hope people will continue to tweet on #BMJCovid, and this session will be recorded and available later. But just to bring things to a close, I wondered if we could just go around and hear from each of the panelists what you think this means for the way forward. Nisreen, you've already talked to us about the public health messaging has got to change in light of long COVID. What does it mean, people might say, about the future for research? What does it mean about the future for healthcare provision? And what would you like to see happen now? If I could go around very quickly from each of you on that. Nick, why don't you start?
I think Nisreen's point about the opportunity of now, with some wholesale testing, getting more information about it, I think is very important. But we also need to contextualize it with the impacts of any old viral illness, as I would say, and in particular I would encourage Valentina to frame her data in that context.
Thank you very much, Nick. Valentina, your thoughts on the way forward?
Thank you. It's a fantastic introduction, not just the viral illness, but also other autoimmune illnesses. In this respect, I would really like to emphasize that even though I have an expensive machine, I use it in a humble way. I'm trying to validate the symptoms that patients have, and nobody believes them. How many times do we see patients struggling, having seen a lot of specialists, and actually when they come to us, we give them the diagnosis, and they are grateful for it. I wish I could exclude the disease instead. So use us much more.
Thank you very much indeed, Valentina. Thanks for your contribution. Trish.
Well, I mean, given that I'm a researcher, I would say that you know, my two pence at the end of this webinar is that we need more research. I think we're all agreed on that. One of the things I think we need, and again this came up in the chat, is to properly code what is going on with post-acute and chronic COVID, and to use routinely collected patient data from primary care and also secondary care to follow up patients with this condition, so that in a year's time we can all come back and say, now we know what was really predicted, and now we know the kinds of tests you need to do, all that kind of thing. Unless we're doing systematic research, that's not going to happen. So you know, this, from the research point of view, in a way this is quite exciting, although you know, I do acknowledge the dreadful human suffering that's happening. So yeah, hope everyone's the GPs have joined the Royal College of GPs Sentinel practice system, and Simon Delusion's collecting lots of data on that. So a little bit of a plug for his work there.
Thank you very much, Trish. Tim.
I like to obviously see every long COVID patient being logging themselves on the app, so we can link their particular symptoms, their clusters, with their antibody status and swabs and etc., and use that as a basis to start trials. I would be starting trials at 1 month to make sure that we can reduce the numbers of people suffering at 3 months. And the obvious one, you know, you start steroids. You know, it seems, you know, it's cheap, it's pretty safe, and let's have that as the #1 trial, and see if we can reduce the number of people still suffering at 3 months, and give us an idea of whether, you know, that approach is going to work.
Thanks very much, Tim. Nisreen.
Well, my final word really is to say we really must count health affected by COVID, not only count lab tests and deaths. And my plea really to the WHO, to all national public health bodies is how do we count it? We don't know exactly what it is. Well, let's try and count who's properly recovered from the virus, because at the moment this is extremely loosely defined. Who's actually now back to their baseline health after having the virus, and who's not? And then in that pool of people who are not, we need to do the research and follow up and actually, you know, to direct care for them. But also quantifying that is so crucial to the next stage of managing the pandemic, because the whole, the public health response would change. If this is a significant problem, there's so much uncertainty attached to it. It needs to be transparently quantified and communicated to the public so that they can make judgments about their risk-taking in the pandemic.
Thank you, Nisreen. And Paul.
I think what's tremendously exciting, Fiona, is you've brought together a multidisciplinary team with a variety of perspectives, both from general practice to research to clinical care to public health, and the way to advance forward in the care that we need now and the guidelines that we need now is to continue to do research, but use dialogue and inferences that cross disciplines under the hat of rehabilitation.
Thank you very much, Paul. Thank you very much to all of you for taking part in this. Thanks to the audience for your questions. Sorry we didn't get to all of them. This is one of a series of webinars we're going to be doing on COVID. As Paul has just said, and we've all acknowledged, it's a multidisciplinary condition, whether acute or chronic, and we're going to be trying to go through the major disciplines that have been affected by COVID-19 over the next few months. So I do hope you'll sign in for those as well. Please do continue tweeting on BMJ COVID, hashtag BMJ COVID, and please do send any comments via bmj.com via rapid responses. Thank you very much again, and keep well, keep safe. Thank you.